Today, we will be talking about an overview of adult congenital heart disease. And we'd like to remember that adult congenital heart disease is a relatively new subspecialty of cardiology, and the patients involved are increasing, and we should always know something about the management of such patients. I will divide my talk into an introduction, which will include an adult patient with congenital heart disease, specifically tetralogy of Fallot. We will talk a bit about the epidemiology of adult congenital heart disease. The important thing is the natural history or the unoperated survival, and then the survival after pediatric cardiac surgery, care of the patients with adult congenital heart disease, the guidelines of this care, and the take-home message. The introduction, as I said, will include this boy, John, who was born in 1941 with tetralogy of Fallot. In 1945, at the age of 4, John became the first Canadian and the third person in the world to receive a Blalock-Taussig shunt. As you know, the Blalock-Taussig shunt is the original shunt at those days, which involved bringing down the subclavian artery to the pulmonary artery. Today, the modified shunt has an intergraft between the two. He attended school and university, Cornell, and he got a degree in hotel and restaurant administration. In 1965, he got married and had 4 children. In 91, John was 50, and he had surgery for his Fallot. He removed the shunt, he closed the VSD, and had a pulmonary valve replacement. And recently was elected chair of the International Congenital Heart Coalition. The message I want to show you here is that it's never too late to repair a congenital heart disease, especially tetralogy of Fallot, if hemodynamically and technically possible, of course. And the other message is that this patient who has reached the age of 50 may have other comorbidities, including dyslipidemia, hypertension, diabetes, and coronary artery disease. And of course, by coronary angio, before he did his surgery, we were sure he didn't have any coronary artery disease. Now we come to some definitions and causes of congenital heart diseases. So we'll start by the definition of what is a congenital heart disease. Obviously, it's abnormalities that occur as a result of cardiac defects during embryonic development of the cardiovascular system. If these defects or others do not lead to death of the fetus, the infant is born with a congenital heart disease in about 8 per 1,000 live births. Majority are without a known cause, or a multifactorial, as they say, multifactorial cause. But there are a few that are known to be associated with congenital heart disease. Trisomy 21 is known to be associated with atrioventricular septal defects or endocardial cushion defects. The 22q deletion syndrome is famous for great artery malformations, including Fallot's tetralogy. Lithium, the drug lithium, which is an antidepressant, can result in Epstein's anomaly, and the mother's affection with German measles or rubella can cause peripheral pulmonary artery stenosis. So these are examples of known teratogens or causes. Adults in this context are defined as those who have reached the age of 16 years. Who are the adult patients that we are talking about who have congenital heart disease? Patients that are diagnosed as adults. These comprise about 10% of the patients. And patients diagnosed in infancy and childhood and have reached adulthood. Many need lifelong follow-up. They include patients with mild lesions who are just followed up, patients who had significant lesions and have had surgery or have catheter interventions and also need follow-up, and neglected disease, obviously, who will continue to need follow-up until their demise. Children with congenital heart disease should be treated only for their symptoms. Parents should be advised to keep them warmly clad. I am not talking about today, I am talking about more than 100 years ago in the Principles and Practice of Medicine, Sir William Osler. This was one of the famous treatment of congenital heart disease. At that time, there was no treatment. So just keep the child warmly clothed, and so it avoids chest infections and flus and viruses and so on. Since the time of William Osler, a span of more than 100 years, the survival rate of children with congenital heart disease have improved to a great extent due to the great advances in medical, interventional and surgical management of children with congenital heart disease. And we can see from this graph that children with congenital heart disease in the 1940s, maybe only 15% or less survived, whereas today we have patients up to 95% survival to adulthood. What is epidemiology? We're talking about the epidemiology of adult congenital heart disease, but what is epidemiology? It is a study of how disease is distributed in a population and the factors that influence or determine this distribution. It's difficult to put a true figure for the prevalence of this heterogeneous and challenging population. In the US, it is calculated to be approximately 1.5 million adults with congenital heart disease. In Egypt, with a population of 100 million and a birth rate of 2% annually, you get about 17,000 new congenital heart disease per year at present. Probably about 12,000 of these will reach adult life. That's approximately 70% compared to 90% or more than 90% in the West. In 1965, if you look at those pie charts, you can easily see that congenital heart disease was far more prevalent in the pediatric age group, 70% compared to 30% in the adult. In the year 2000, approximately half and half, 50% pediatric and 50% adult. In 2010, 60% are now adult patients with congenital heart disease, and 40% are still infants and children. Patients reaching adulthood with congenital heart disease, as you can see, it is a kind of a what should I say, a step ladder thing. In the 70s, there were 325,000 children with congenital heart disease. In the 80s, it was half a million. In the 90s, 750,000. In the year 2000, it was 1 million. And today, or it's more than that, but it's around 1.3 million or 1 to 1.5 million patients with adult congenital heart disease. This is just to show you an example of a clinic, two tertiary care centers, and showing you the prevalence of the patients that came to the clinic in those centers, the Mayo Clinic and the Toronto Clinic, and you can see the age range of the patients frequenting the clinics. More than 75% are in the 21 to 50 year of age group. Okay, there you go. More than 75%. If we look at this graph, we can easily see that the improvements that have occurred in the treatment, especially surgical treatment of infants and children with congenital heart disease, especially the severe congenital heart disease, has improved a great deal. You can see from the slides here that the prevalence in adults and the median age of patients with severe congenital heart disease increased in the general population from 85 to 2000. In 2000, there were nearly equal numbers of adults and children with severe congenital heart disease. Congenital heart disease beyond the age of 60, emergence of a new population with high resource utilization, high morbidity, and high mortality. This was a paper in the European Heart Journal. Their conclusion was there is a growing number of elderly adult congenital patients with high mortality rates and the high utilization of healthcare resources compared with young patients. Acquired morbidities such as coronary artery disease seem to be key determinants of the outcome in this older population in conjunction with the underlying congenital heart disease. Let's talk about the unoperated survival and survival after cardiac surgery. Common defects with expected adult survival, that is without doing surgery. Acyanotic malformations without a shunt, bicuspid aortic valve and coarctation of the aorta. Acyanotic without a shunt, right-sided, pulmonary valve stenosis. Acyanotic malformation with left to right shunt at the atrial level, secundum ASD, and at the aortopulmonary level, PDA. Common defects with exceptional adult survival, that is unusual for them to reach adult age without intervention, that includes ventricular septal defect and tetralogy. Uncommon defects with expected adult survival will include many: situs inversus with dextrocardia, corrected TGA, discrete subaortic stenosis, Epstein's anomaly, pulmonary artery stenosis, primary pulmonary hypertension, partial AV septal defect, sinus venosus ASD, partial anomalous pulmonary venous correction, and there are, of course, others. Uncommon defect with exceptional adult survival: congenital obstruction of left atrial flow, such as left atrial ring, supravalvular aortic stenosis, vascular rings, double outlet right ventricle or left ventricle, which includes the Taussig-Bing anomaly, anomalous origin of the left coronary artery from the pulmonary trunk, aortopulmonary window, truncus arteriosus, univentricular hearts, complete TGA, tricuspid atresia. Survival after pediatric cardiac surgery. And this is more important to know because a lot of adult patients now have surgery and they do come as adults for follow-up. A great success story of modern medicine, a new population of patients, many not cured. Most adult patients have undergone repair and not corrective surgery. Further surgeries, arrhythmias, heart failure, and risk of premature death coexist. Some present late in adulthood and require proper care and follow-up. This image shows the success story of pediatric congenital heart disease. And you can see how it started many years ago. You get the child born with the congenital heart disease. Today there is a fetal diagnosis of congenital heart disease which was not present 20 years ago. This has helped plan treatment for certain patients. Then there are the advances in the neonatal ICU care, the improved surgical techniques, early complete repair, which is an important aspect of a good long-term survival, lower perioperative mortality, increased early survival, increased midterm survival, and that will lead to an expanding population of adolescents and adults with congenital heart disease. This is an interesting graph showing you the survival of patients, of all the patients of separate diagnostic groups and the general population. The general population, as you can see from the dashed line, which is this one, this is the key of the graph, and this dashed line shows you the general population. So 45 years, 95% of the patients are alive, or a little less. And then you come to the separate diagnostic group and all patients years after operation. So this is survival, and this is the years after operation. And you can see that all the patients together is this straight line, as you see from the key. Around 80 patients are alive 45 years after their surgery. And then we start dealing with the separate diseases. You can see the ASD is close to the general population, 45 years after surgery or intervention. And then you have PDAs, which comes after that. This is the ASD, this one that I'm on. And then you have the PDA, which is this one. It's a bit less. And then you have the VSDs. Then the VSD, where the CoA first. Yeah, this is the coarctation of the aorta, these triangles. There's a little drop here at the age of 35 years after surgery. And then you have the VSDs. You have the tetralogy of Fallot. 45 years after surgery, a good 60% are alive, or 55%. And then you have the transposition of the great arteries. Around 50% are alive 35 years after surgery. And then you have the univentricular hearts, which are the worst prognostic ones, and those are usually around 20% are alive 35 years after their surgery. Adult congenital heart disease is a challenging population. But why is it a challenging population? It is a growing population. Many more patients are coming into our practice daily. A very heterogeneous population. You don't get a patient with hypertension or systemic hypertension and that's it. No, you have a patient with ASD who's had a device in. You've had a patient with ASD who had surgery. You've had a patient with ASD who's recently diagnosed in adult life, and so on, and many different types of congenital heart disease. The absence of large clinical trials and definite guidelines for their care mostly consensus of opinions, because you cannot have such a heterogeneous population and get enough patients to have mega trials. Frequency of redo surgical or catheter intervention, including EP studies and device implantations. Lifelong follow-up and care. Now we have patients with heart failure as a result of the congenital heart disease, infective endocarditis, comorbidities of the adult type. Do we need specialized centers? Definitely we need specialized centers for the proper diagnosis and assessment of these patients, follow-up and care of the patients, initial or repeat surgical or non-surgical treatment, risk assessment and care for non-cardiac surgery, pregnancy and delivery, and comorbid conditions. You must remember that adult congenital heart disease has to be a multidisciplinary type of care. As you can see, it involves all aspects of a hospital, and therefore the center should be present in a multidisciplinary hospital with OB/GYN, with surgery, with internists, psychiatrists, the lab, of course, the imaging, cardiac surgery, cardiologists, and all that. Pediatric cardiologists, okay? And the cardiologists include the adult and the pediatric, of course. All these come together to help follow these patients in a proper way. The cardiac lab, as you all know, it's a comprehensive cardiac lab for the care of these patients and should include, of course, electrocardiography, the resting and stress, Holter monitor, radiology, which includes simple X-ray, MRI, and CT, echo, including transesophageal echo, 3D and now 4D echo, the electrophysiology lab, cardiac catheter, and interventions. Among the things that we need to do for doctors and young doctors who want to train in adult congenital heart disease is there has to be a program for training specialists, which should include defining and implementing the educational requirements that you need to specialize in adult congenital heart disease, a workforce to staff specialized units, trainees from pediatric or adult cardiology, and define the training programs and a formal certification process. A very important aspect of adult congenital heart disease is the transition of care from the pediatric to the adult cardiology service. very important. Caring for patients with adult congenital heart disease needs to be well organized. The care should be provided by regional or national centers. One expert primary center should be available to serve a population of around 10 million people. So in actual fact, Egypt will need 10 centers. For Greater Cairo, for example, 2 centers are needed. Secondary centers with outpatient-based services linked with the primary center is a must. Proper transfer of care from the pediatric to the adult service is very important. They've even published practices on managing the transition to adulthood for adolescents with congenital heart disease. The transition process, medical and psychosocial issues involved, and that was a scientific statement from the American Heart Association in 2011. So, for example, recommendations for adolescents. The timing of transition should be guided by the emotional maturity and developmental level, as opposed to chronological age. For transition planning, this is important. So it depends on the maturity of the person you are going to transfer. The adolescent should be engaged in transition planning, and he should be engaged in that plan. The adolescent should be asked about their understanding of their disease in relation to their current health status, restriction on activities, and future goals. The adolescent should be encouraged to share about quality of life issues, physical restrictions, school peers, social relationship, and so on. The adolescent's fears and concerns should be acknowledged in an empathetic, non-judgmental manner. The pediatric cardiology provider should initiate and work together with the adolescent on a transition plan using a transition resource binder and/or health passport. Providers should begin to direct health discussions more toward the adolescent than the parent. Quality of life issues should be discussed privately with the adolescent and be flexible. All these are very important, and they are all class 1 level of evidence C as regards guidelines. Recommendations for parents are also class 1 and level of evidence C. The pediatric cardiology provider should initiate discussions on transition planning and partner with parents in the process. The pediatric cardiology provider should solicit information about parental perceptions of their child's quality of life. The pediatric cardiology provider should encourage discussion of parental understanding of their child's disease and concerns in relation to future goals. The pediatric cardiology provider should be non-judgmental and empathetic when acknowledging fears. Congenital cardiac lesions and peri-operative risk for non-cardiac surgery. This is another subject that's extremely important. As the adult patient with congenital heart disease grows, he has, just as any other person in society, he can have problems such as acute appendicitis, gallbladder disease, anything that may need non-cardiac surgery. And so we need to assess the risk. High-risk patients are obviously those with severe pulmonary hypertension, primary or secondary, cyanotic congenital heart diseases, New York Heart Association class 3 or 4, severe systemic ventricular dysfunction, ejection fraction less than 35%, severe left-sided heart obstructive lesions, and those with moderate risks are those with prosthetic valve or conduit, intracardiac shunt, moderate left-sided heart obstruction, and moderate systemic ventricular dysfunction. The coming 2 articles of the European Heart Journal, published in 2006, were as a result of the European Heart Survey on adult congenital heart disease, which we had the honor of being a part of with a few cases. And these are the articles that they published from the group that was admitted to the survey. The first one is Adherence to Guidelines in the Clinical Care for Adults with Congenital Heart Disease, the Euro Heart Survey on Adult Congenital Heart Disease. They concluded that guidelines have an important role in the actual clinical care of adults with congenital heart disease. However, large outcome studies are needed to develop more precise guidelines. Another publication, The Spectrum of Adult Congenital Heart Disease in Europe, Morbidity and Mortality in a 5-year Follow-up Period. The conclusion was the spectrum of adult congenital heart disease emerging from this survey is one of a predominantly young population with substantial morbidity but relatively low mortality in a 5-year period. The take-home message that I have to give you from this talk is adult congenital heart disease is a specialty in evolution, or a subspecialty if you like. It is of utmost importance to remember that it is a multidisciplinary care, so a center of this type should be present in a general hospital with all the facilities available, and these patients need our commitment towards their care and needs, as they will become a larger part of our daily practice in the near future.